Yeah, so we are team FairPlay, which is fair phenotyping and genotyping using augmented electronic health records. And we're representing the University of Illinois at the AI for Health Bowl. Yeah, so this is our team. We're made up of Siddharth, Kushika, and myself, Brandon, who are all PhD students at the University of Illinois. And then our last team member is Dr. Adam Cross, who's a researcher at UIC and a hospitalist at OSF Children's Hospital of Illinois. And then we also have our faculty advisor, Joang Sun. So we'll start by introducing the problem that we're seeking to address. So there exists this cycle of bias in healthcare that causes inequities in treatments and outcomes. So it starts on the left here with the disparities in healthcare access, especially for healthcare and minority groups, due to a variety of structural reasons, which Blair and our keynote speaker addressed very well at the start today. These disparities in access are then manifested in unrepresentative data in a variety of sources, such as hospital visits, medical experience and training, both in medical schools and the field, and then clinical studies that drive medical progress. This relative underrepresentation of minority groups then naturally causes doctor bias and algorithmic bias, with medical expertise being tuned specifically towards majority populations. And while there's a hope that machine learning models could assist and fix this problem, we see that they fail to do so, and we are left with misdiagnosis and mistreatment, especially for minority groups again, and then have time, money, and even lives wasted, which only spurs on the restarting of the cycle by further stratifying healthcare access and effectiveness. Now, as we dive a little deeper into the cycle, we start with those unrepresentative data sets, and specifically in clinical studies. So here on this slide, we see that white population is overrepresented in clinical trials, making up 83% of the trial population, while Black and Hispanic groups make up just 5% and less than 1% respectively, despite being a much larger part of the overall population. And we see a similar pattern in GWAS, or genome-wide association studies, where globally less than 12% of the world's population is of European descent, but well over half of these individuals in these studies fall into those groups. These clinical studies drive medical progress and tailor medicine to our wider population. So the unrepresentativeness of the subjects causes the problems even before we get to, disparate training examples or hospital data or clinical experience. And so these kind of environmental factors and inputs manifest themselves as disparate healthcare outcomes. So this table shows, disparities in health quality measures, a variety of those measures by racial groups compared to the white population. And as we can see, minority groups perform worse in the vast majority of health quality measures, especially Black and Hispanic groups. This includes statistics such as African Americans being 35% more likely to suffer from heart disease, Native Americans being over twice as likely to be uninsured, and various minority groups having much higher cancer mortality, infant mortality, and non-treatment rates, among many other things. And so while there's a hope that machine learning algorithms can offer an unbiased face to assist doctors and help mitigate these problems, it is well known through a variety of examples and publications shown here that they do not, and they instead maintain or even amplify the underlying biases. So I'll now pass it over to Kushika to discuss the two specific domains or examples that we seek to analyze and address with our project.
So the first data modality we are focusing on for our patient record augmentation is phenotyping. So phenotyping refers to placing patients into standard disease categories according to their symptoms, severity, disease mechanism, and other information. But in some cases, identifying the proper phenotype for some patients can be tricky and time-consuming. And in such cases, in silico phenotype predictors can be helpful for early diagnosis, and more importantly, for identifying severe risk patients at an earlier time. Also, phenotyping algorithms can assist to cross-check doctor-recorded phenotypes in EHRs to potentially check for any misdiagnosed cases. And along with improving patient care, accurate phenotyping can also benefit business revenue of hospitals. By proper reporting of severe risk phenotypes in the treated patients, hospitals can gain millions of dollars, which otherwise they would have missed due to incomplete and incorrect diagnosis. So there have been reports that existing phenotyping algorithms have been failing to deliver fair performance across different subpopulations. For example, severity predictors are failing to pick up to detect high-risk patients in minority populations, and worse, sometimes even prioritizing lower-risk patients from majority population. And in another study, image-based disease classifiers were shown to learn to model the racial covariates instead of learning to extract disease informative features from input images. And also the datasets currently predominantly used for training the current phenotyping models are also heavily biased in terms of underrepresentativeness of different populations with geographic location, socioeconomic status, and other factors. The next data modality that we are focusing on for augmentation is genotyping. So genotype refers to the collection of variations in an individual's DNA sequence, and human DNA sequence has around 3 billion genetic codes, and among which more than 99% is same across individuals. But the variations we have in the rest of 1% of the genome is what makes us unique in terms of our height, weight, physical appearance, and also disease mechanism. For example, in a study, it was shown that in metastatic prostate cancer, Black patients have significantly more mutations in androgen receptor genes and DNA repairing genes compared to white patients and Asian patients with the same phenotype. So modern clinical practice, which is continuously moving towards personalized medicine, clinicians need to take into account the individual specific and subpopulation specific genetic factors that are driving the same disease in different patients in different populations so that they can tailor personalized medications and treatments and tests to the patients. For this purpose, genomic medical models are increasingly gaining popularity to assist in personalized medicine. But the trouble is there have been reports that these models are also failing to deliver fair performance across subpopulations. For example, warfarin, which is a very popular anticoagulant and has very high interpatient variability. So there are algorithms for predicting warfarin doses based on a person's genotype. But a study has shown that the algorithms are consistently predicting incorrect doses for particularly African American patients while performing well enough for majority of the population. And in another study, it was shown that oncogene predictors, those are failing to detect causal genes from tumor samples of minority population while performing quite well for majority population. And then the predominant data sets we have with genomic information like TCGA, UK Biobank, those are also suffering greatly from the underrepresentativeness of diverse populations. So now I will hand over to Siddhartha, who will talk about our proposed solution.
Thanks, Kaushika. So let's come back to where we started with the cycle of bias in healthcare. Remember that basically every single team in today's conference has talked about how data and current data sets in clinical practices are relatively unrepresentative of the real population. So this is where we've chosen to break the cycle. How do we do this, however? Well, what we're going to do is we're going to take unbalanced data sets. We're going to analyze these and specifically really focus in on intersectional differences. Specifically, let's take the example of African-American women because they would be very underrepresented in a lot of these data sets. What we're then going to do is using methods that we have already developed in our time as PhD students, we're going to synthetically generate patient data on the same quality as that of what real patient data already exists. This is a two-step process whereby which we first augment the data set with synthetic patients, and then we impute missing genomic biomarkers. What we then do in our third step of this pipeline is we build machine learning models, specifically phenotyping and genotyping models, as we mentioned, that are trained on these balanced data sets. As most of the members of this conference are pretty aware, machine learning models trained on unfair data sets are usually going to be unfair. And thus we hope to remedy this by using a balanced and fair data set to in turn make our machine learning models much more fair. What then happens is we're going to deploy this to EHR software via an FHIR app, and all these patient classifiers will then be available to be deployed into hospital settings to help clinicians both bill more accurately, which saves the hospital money, and prevent, as well as improve patient care by having less misdiagnosis. So let's talk about like what the actual software is going to kind of look like. Well, it's going to integrate all of our predictive models, our pre-trained models, and it's going to integrate into EHR software via FHIR app, as I said, and it helps administrators with billing, and it helps diagnosing and coding for doctors. So therefore, our pilot study is going to kind of look like this. Using some publicly available data sources like MIMIC3 and now MIMIC4, which are public inpatient EHR data sets, combined with genotype data sets from UK Biobank, and finally, in collaboration with hospitals that sign up for our platform, we'll use all these data sets to make sure that we have sufficient amount of data And then what we'll do is we'll augment these data sets with our synthetic patient data, specifically focusing on minority populations. The pilot test, therefore, is going to be simulated via a test set. And what we want to do is demonstrate that a rising tide does in fact lift all ships. Specifically, because we help improve minority group accuracy with these new phenotyping and genotyping models, we're going to also improve overall accuracy in the health sphere, and it's going to be available to clinicians and practitioners via our FHIR app. And an example of where this can be used is in either the OSF healthcare system, as Dr. Adam Cross is a close collaborator with our group, and other hospitals that our lab has contacts with in the Chicago area. Finally, we want to talk about some ethical considerations, specifically on the left, some challenges, and on the right, some efforts we're making. So on the left, we look at privacy concerns. All of the data from data sets like Mimic, Hospital Collaborators, and UK Biobank are relatively de-identified. We can't tell who is what in the data set. All we know are the biomarkers that are relevant to our phenotype and genotype models. More importantly, the synthetic data that we actually generate doesn't have any sort of it's not an actual person, so there's no actual privacy concern here. And our algorithms don't actually leak any of the training data that it was trained on. And the efforts we're making to reduce algorithmic bias by A, incorporating data from multiple sources, and B, by balancing the data set with our bespoke methods, actually show that we're going to end up reducing algorithmic bias in the long run, which means that this isn't something that we have to worry about. And in fact, other teams at this conference could actually benefit from our tools for use in their products as well. So thank you for listening to our presentation, and we welcome any questions you have at this time.
Yeah, thank you for the presentation. I think I agree with the general idea of combining data sets to be able to diversify and get more diverse data sets. The data sets I think you named are very, very different. Mimic is a single center ICU data set. UK Biobank is obviously, a much more large scale effort. And then Hospital Collaborators, I think there's a question there. We talk about data imbalance sometimes as like, data imbalance means many things. And, one of the things it means is certain classes of disease you don't have enough cases of, and you try to balance them by synthetically generating kind of more cases. And this, idea has been labeled like SMOTE resampling or synthetic minority oversampling technique. And this technique artificially balances certain things, but, I'm sharing a paper in chat that that host panelists can see that draws some questions around, does this actually work? Because your synthetic data needs to be similar enough to your source data where it actually is meaningful. But it needs to be different enough that it's de-identified. And I think that those things are achievable. So I think there's an interesting concept here, but it'd be great to see some evidence that you actually can execute on this idea, because I think a lot of the synthetic minority oversampling technique literature has been kind of misguided in the sense that it has to do with the way risk prediction models are implemented and not necessarily with the underlying fixing of the balance issue.
Yeah, we definitely agree. And we are aware that a lot of kind of existing synthetic balancing techniques have shown mixed results. So we use, and if I go forward a slide. So we have this this network, which basically generates patients conditioned on certain demographic and outcome features or labels. And so it's not really oversampling. It kind of, the way it works is it's learning global patterns and being able to infuse, phenotypes from demographics or, outcomes to kind of balance data sets in all ways while maintaining coherence enough to be used. And we can also share some results that we've shown that the model's data can be used for synthetic training in machine learning models effectively.
Maybe I can add a couple more thoughts here. So it's tricky, right? Because when you talk about minorities, like we talked about earlier, some of the minorities actually do have different genetic makeup. So, but not all of them, right? Not 100% of African Americans have the same kind of SNPs that most of them do. So I don't know if you take into that account that. And then the second thing I was going to say, then the flip flip side of that, which is more true for rare diseases, there's not always a genotype-phenotype correlation. So you could have a genotypic, I guess, a SNP that actually does not relate to how severe the disease is. So I don't know if that is your method only related to when there is a very tight genotypic-phenotypic correlation?
So,
yep.
sorry, I'll probably start and Brandon can like jump in, feel free to jump in whenever. So right now, what we are planning is to consider learn the global pattern of the correlation between the ethnicity and other factors that creates like subpopulations and also the phenotypic correlations. So it's like for rare disease patients, I think we kind of for now are probably focusing on the augmenting the disease for which we have sort of well understood genotype phenotype associations. And we will, while imputing the genomic markers, we will take both into account the demographics, ethnicity, and also the existing phenotypes and other EHR records into account. So then say not all sub-Saharan African people have like a particular genotype, but there is a prevalent mutation which causes the like elevated glycated hemoglobin. So if you have that in your lab test, and if you know the demographic is like from that sub-Saharan African region, then you will probably introduce that mutation in your synthetic data. But if your lab test does not show that elevation in hemoglobin, then you probably will be less likely to introduce that.